Now it is my pleasure to
Thank you.
introduce our first speaker of the day, Joseph Nardolillo, Assistant Professor of the Department of Pharmacy Practice and Clinical Research at the University of Rhode Island College of Pharmacy.
Good morning, everybody. My name is Joe Nardolillo. As I mentioned, am a clinical assistant professor here at the University of Rhode Island. Very excited to be with you all today to talk about probably one of my favorite topics, which is lipids and lipidology. We all hear and talk about, and whether we're in the primary care, ambulatory space, outpatient or inpatient, we learn about lipids all the time. They're in cardiovascular risk reduction. It's one of our main parts, but as one of my favorite topics, I always say sometimes the most misunderstood and forgotten part of all of our different management of cardiovascular risk, and something that we probably all know a fair amount about, but really is a changing landscape. And we'll chat a little bit more about that today. A lot of my previous work is in different primary care based settings, and now recently switching over to a little bit more of a research oriented role, helping to get patients to all different backgrounds on these sorts of therapies. So really excited to be here with you today. As we chat about our conversation today, we will describe some of the different roles of statins and non-statins, assess our different cardiovascular risk of patients with biomarkers and some of our different risk calculators, as well as developing our person-centered care plans. Again, you may have seen this at first and said, oh, why are we learning about lipids, right? I've learned about these many times before. But we really are on really the forefront of a lot of emerging therapies and some of our older therapies having new tricks. So I have no financial disclosures today. So to kind of set the stage for us, I want to paint a little bit of a picture. So let's imagine we have a patient, SD, a 65-year-old male who's been seen in primary care for follow-up, has a history of myocardial infarction in 2021 with type 2 diabetes and hypertension. Patients taking atorvastatin 40, metoprolol 50 once a day, losartan 100, metformin twice a day, and aspirin. Looking at the lipid panel, the patient's LDL is about 87, an A1C of 6.8. Renal function looks great, and blood pressure of 128 over 78. The patient's BMI is about 30.9. But otherwise, I think that if we were to consider one of our patients, I think for many of us, this would be a pretty healthy patient, right? A lot of my work has been in value-based care and in population health. This patient would pretty much be meeting every measure, wouldn't be flagged on many of our aspects besides just, having a history of cardiovascular disease. But it actually appears to be managed quite well. So thinking about on your end, if you were to encounter this patient, what would you potentially want to do for them? Well, really, as we start to consider the world we're in today, there was probably some therapies that, we're likely missing or the patient would have indications for. We could potentially increase the statin dose to reduce some of their cardiovascular risk. Consider an add-on therapy like ezetimibe, PCSK9 monoclonal antibody, some of our newer agents like inclisiran, maybe a bempedoic acid if we wanted an oral option, icosapent ethyl as we looked at the patient's lipid panel and specifically their triglycerides, a GLP-1 agonist, right? Knowing that our patients with diabetes may also benefit from an established cardiovascular disease, may benefit from the addition of a GLP-1 or an SGLT2, irregardless of their A1C. And now maybe even colchicine, right? An agent that we've seen for a long time, potentially having more benefit. So as I now dive in, we're going to go through a couple aspects. Some of this may be review, while it really does help to set the stage for both the medication and some of the assessment techniques we're going to be describing. I do want to also add too, feel free to throw comments in throughout the chat if you have questions on a specific topic. We'll also take some time for questions at the end, but sometimes as you go through, it's easier in that moment to think your question, and I'll try to get to it as soon as I can. So now we're going to chat a little bit about baseline foundations of lipid management, specifically some of the pathophysiology and of atherosclerosis, as well as our most recent multi-society guideline from 2018 from the American Heart Association, American College of Clinical Cardiology, and really also the organizations such as the American Pharmacists Association were involved in some of these guidelines. So as we think about, lipids are needed, right? There's been many changes and phases of both diet aspects over time, as well as, medications of, how low do we go? We can't go too low. We should have no fat. We should have high fat. Really, we've seen lipids and fats in our diet, as well as, some of different aspects of our health have a very different role and some conflicting thoughts. And a lot of that is largely because lipids are important. They help maintain our cell membranes in our phospholipid bilayer. They are an energy source, one of the best energy sources where they can store and provide direct fuel. They're a building block for many of our other key aspects of our body and our metabolic functions, such as steroids or bile acids and vitamins. They can be metabolized both, exogenously, so or be supplied, I should say, exogenously. So that's things from food as well as endogenously. So your body is constantly a recycling plant of different aspects and parts of our cholesterol and our lipids. I teach these to our P1 pharmacists now and our pharmacy students, and it's one of the second topics they learn beyond hypertension. So really doing a lot of analogies over time is where I've come with many of the lipid treatments. So if you hear me referencing a few, it's many years of working with our pharmacy students. But when we think of the lipoproteins, they're packaged as apolipoproteins, so kind of a marker for each one. They have cholesterols as well as triglycerides, and they're really there. It's kind of the vehicle for them in order to facilitate a lot of these different metabolic functions. We're going to have ones with different combination of some of these different aspects, the apolipoproteins, cholesterol, and triglycerides. So they'll each have their own little recipe. As you see in this image on the right here, HDL, high density lipoproteins, are really saying that they don't have a ton of that extra cholesterol and triglycerides present. Then we have some of our intermediate ones, as well as our LDL, our low density. It's a little bit of inverse thinking that the smaller the molecule, the lower the density. So our second smallest of our quote unquote, bad cholesterol are ones that can be pro-atherosclerotic. We'll talk a little bit more about that, or our LDL, which have a little bit more of the cholesterols and triglycerides. And then we have our up to our chylomicrons, which are really the first formation after we eat. So if you were to eat something like a high fatty meal, you have a lot of fat that needs to be absorbed and transported throughout the body. Your chylomicrons are really large. We call them fluffy very often, and that they're not densely packed, but they can provide a lot of energy and transport some of the different lipids around the body. And when we talk about dyslipidemia or some of this different pathophysiology, dyslipidemia really is kind of our broad term. We say dys, meaning it's just something of not what we want it to be, related to our lipids. But specifically, we often refer to hypercholesterolemia, right, which is some aspect of high cholesterol. And this can actually even be broken out into different subgroups. So we're not going to dive into it a ton today, but as we talk about different familial hypercholesterolemias, you may have, like, for example, hypertriglyceridemia, where your triglycerides specifically are elevated. But really, over time, they lead to excess cholesterol around the body being deposited in what we call atherosclerosis, right? There's a formation of plaques. And this is really, in the image on the right, you can see a progressive process. But in our 20s, most of us have developed at least some fatty streaks, which are really kind of this intermediate on the left side here of this timeline. Really, as it builds up, it's really these initial deposits. Over time, these initial deposits are placed. Once they are placed into our vasculature, things such as on the coronary heart, the coronary artery, or even down in our periphery, such as in our legs, which is what leads to peripheral artery disease, they are deposited. They react in the body, tries to tackle them with things such as macrophages, and really leads to a lot of inflammation. That inflammation can have plaques that form and increase over time, which can often lead to our heart damage, from potentially occluding or having a thrombus form on some of these more narrow pathways now. Really, I often use an analogy of pipes for our students, right? Your pipe, pour something down at once, not going to have a problem potentially over time. If you're pouring oil that you're cooking with down every single time, you're going to have some problems. When we talk about our different dyslipidemias, we have our primary, which is something that is genetically derived, something such as familial hypercholesterolemia, which we're learning a ton more about day by day now, as well as our secondary, which is our most common we're going to see, or acquired over time, which is the contributors to our ASCVD or atherosclerotic cardiovascular disease. Again, really can be mediated by things such as diet, exercise, and medication. So really, we are at a point in why I like to focus on lipids for conversations such as these, as well as those centered around public health, is, there's always information about diabetes and hypertension. And while I absolutely love our other cardiometabolic counterparts and manage them myself, I think that lipids are the ones where we don't always see the problem, right? Patients don't see it. It may not be assessed all the time. It's something that they're not going to feel necessarily. When we think about it's how the level of undermanagement can occur, LDL is the eighth highest risk factor for death in the US. 1 in 7 adults and 1 in 7 deaths is due to coronary heart disease. Really, 86 million Americans can have elevated total cholesterol over 200. And only about 50% of the people in the US who may benefit from therapy are using it. And really, only 20% of patients with heart disease achieve their LDL goal, right? Thinking about this in the context of our other disease, if anybody works in, value-based care, ambulatory care, imagine if only 20% of our patients had an LDL. I'm sorry, had a controlled A1C, right? I don't think we'd be getting many contracts or working and being as boasting the pharmacy as great as we are for many of these reasons. While there's many different factors we need to consider in this process, one of them is social determinants of health. We know that the management and cardiovascular risk is not alone and can't just be solved with just medications, right? We need to consider the environment and the access to our patients have to things like food, the economics. Can they afford treatment? Can they take time off work, right? This is one that I've always thought about, and where the benefit of pharmacy comes into play is that although there's challenges with billing sometimes, it makes us a little more accessible to people, right? We can give them a quick call, check in on their lipids or their hypertension. What is their education? Are they ability to navigate healthcare? Right? We all know it can be quite challenging to be able to coordinate some of these different appointments and accessing medications. What's the social support and community? How much? What is perceived? Like, is a caring for these things appropriate? Is it how prioritized is it with some of their competing responsibilities? And is there any medical mistrust there? And really, our different healthcare access. So, can somebody get the treatment they need on an ongoing basis? Is it accessible? We've talked a little bit about some of these, but just to set the stage so you have both for your reference for the slides and as we talk, right, what are the different terminologies I'm going to use? So we have total cholesterol, or TC, LDL, which is our low-density lipoprotein cholesterol. We have our triglycerides, our high-density lipoprotein cholesterol, our ASCVD, and then, ASCVD kind of being in that bucket terminology. So ASCVD is that umbrella term, right? It is something that is obviously in the arteries, right? Atherosclerotic, as we continue to talk about it, but it's really the umbrella term for coronary artery disease, myocardial infarction, ischemic stroke. And I always say the forgotten of the ASCVD is the peripheral artery disease, right? This is when folks have some occlusion in their lower limbs, which may prevent some of the appropriate blood flow and then can lead to atherosclerosis and tissue dysfunction as well. Our primary prevention, again, are folks without ASCVD, and our secondary prevention is folks with a history of one or more ASCVD events, as those listed above. So as we consider the overall, what I like to call the lipid landscape, things have changed a bunch, which I think is often what leads to some of this undertreatment and some of these confusion that can occur. Right, thinking back to the 80s, we kind of initiated the concept of primary prevention. Maybe we're using bile acids, resins, bile acids, equestrians, resins, right? Nicotinic acid, fibrates. Before my time, these were even statins that were not even around until 1994. So really, as we then see movement, there's more focus on primary prevention and some of the multiple different aspects of medications and their use together. We introduced our Framingham risk calculator, which is built of our large Framingham cohort, really to be able to assess risk in our primary prevention population by looking at some of these factors. 2013 is where we kind of start to go, all right, 40 to 75, we kind of revise our equation with the pooled cohort and say statins, basically. Some of the other uses, of some of the other agents may not be as necessary as we thought. 2018, we start to say, all right, actually, we're going to come back to some of this. We're going to give you some different age groups that we can consider and talk about and really introduce statins as well. And ezetimibe as a reintroduction is really, as well as PCSK9 monoclonal antibodies. And this slide, I think, is where the confusion comes into play, right? We say we've gone from you got to treat to a number to actually, we don't really care about the number that much in 2013. Let's just look at start a statin and how much do you decrease by. 2018, now we're saying, hey, well, actually, I care for some folks if you have really high risk, but don't go too low. Just still make sure you're getting those percent reductions. And what we'll talk a little bit about today is now we're reintroducing this even more in some ways because we've got a lot of really positive data that shows that, some of the concerns we had about low LDL, for example, things such as if you have too low of LDL, you're not going to have enough, you're going to have memory dysfunction, for example. Now we've seen with some of our new agents that can really drop some of these LDLs down to lower levels. They're safe and effective, and there's not as many safety concerns as we may have been considered in the past. So really saying, hey, lower the better in many of these times, and we'll talk a little bit more. Again, just a nice refresher for you, the differences in our intensities of statin. Our high intensity statin is our LDL, which is a decrease. We assume they should decrease about 50% or more. Our atorvastatin and our rosuvastatin. Moderate intensities, we see atorva, rosuva, Simva, again, those lower doses of atorvastatin and rosuvastatin, as well as some of those higher doses of our other agents, as well as our low intensity statin, which was assumed to be about a 30% reduction in LDL or less, which is our simvastatin, low dose, lovastatin, fluvastatin, pitavastatin, etc. While we're gonna, talk about the guidelines, this has kind of been my trick for many years when I think about some of the patients and how we should approach them, right? We have our different statin benefit groups. We usually talk about the main four of them, being some of these established ASCVD, those with really high cholesterol as second, those with diabetes as a third, and those with increased risk, but none of those other factors as a fourth. This is the approach that I share with our students, and I actually feel it's been really helpful for me to even grasp my brain around it a little bit. First question you have to ask when you're approaching a patient, do you have a history of ASCVD? If you do, we kind of go down that treatment pathway of high intensity statin, and then potentially adding on ezetimibe, targeting that LDL of less than 70. And this is kind of, again, all going off our 2018 guidelines. What's our baseline LDL? Is it really high? Is it greater than what we would call 190? Or that would be, something where we should consider really being even more aggressive. We have what we call severe hypercholesterolemia and potentially even familial, when you may have to go down some of those treatment pathways. Do you have diabetes? We know that diabetes is really one of those broad groups now that we say statin is going to benefit most folks, particularly those age 40 to 75, with an LDL of greater than 70. And then lastly, as we consider our everybody else group, is those with 40 to 75 with a 10-year ASCVD risk score. We'll talk a little bit more about that pooled cohort equation shortly, of greater than 7.5%, that we probably should treat if they're above 7.5 and definitely treat if they're above 20. And if not, maybe they don't need a statin. So as we kind of dive through, again, looking at the summary of these, putting together this table, I think is actually quite helpful for me always and someone else to consider. As we think about the ASCVD of 18 to 75, those are our main folks, really differentiating, and this is where 2018 introduced some of the difference between those folks we call very high risk and which is 2 or more events, or people with 1 event and 2 or more conditions. So those may be those other conditions or factors. I joke the word factor or risk is used so many times, so try to parse this out as simple as we can. But really, if let's say somebody has 1 event, but they are greater than 65 and they have a history of hypertension or just hypertension, they would then be considered very high risk. And we would target what we see in this middle column here of less than 70. We would use a high intensity statin, then add ezetimibe, and then move on to a PCSK monoclonal antibody. And what we often call a treatment threshold, meaning that let's say, somebody has an LDL of 80 on a rosuvastatin and ezetimibe, we would then say, hey, you're above our threshold, we want to keep treating. And then we would add something like a PCSK9 monoclonal antibody. Severe hypercholesterolemia is, again, we don't need the pooled cohort equation. That's only for primary prevention folks. When we're doing those, we're targeting an LDL of less than 100. We want a high intensity statin, again, considering to add ezetimibe, and then a PCSK9 inhibitor if needed. Really, and those folks, we want to start considering some of those genetic testing. This has really been an opening and kind of much more wide open experience now of looking at genetic testing related to hypercholesterolemias. A lot of the things that we thought may have just been, bad luck many times, or unfortunately, like very young myocardial infarctions with folks, likely had to do so with some sort of genetic criteria that could have been treated more aggressively and earlier as it pertains to some of these hypercholesterolemias. As you kind of go on, you will be very shocked with some of these familial pieces of just how high we can go, right? Some people may be high as having triglycerides into the thousands of thousands, right? These are people who at 25 may have an LDL of, in the upper 100s and 200s, right? We're not going to talk about it today. One of the things that fascinates me most in the space of lipidology is even things like lipid apheresis, which is for those folks who are so elevated and cannot clear, their body cannot clear these lipids as fast as they can make them. Things where after they've exhausted every treatment option, they actually essentially do dialysis for lipids, in which they pull out some of your blood, centrifuge it, remove the lipids, and take it off manually. So it really is quite an interesting and evolving space, and where many of our medications are being used, because this is where some of our highest mortality is. Again, thinking of our folks in diabetes, we already chatted a little bit about that. If they're greater than 20, definitely be quite aggressive, use a high intensity statin. But if they also have what we call diabetes specific risk factors, these are really folks that say, hey, this is just progressive diabetes, right? Meaning that if you've had it for greater than 10 years, if you have an elevated urine albumin creatinine ratio or decreased EGFR, right? So chronic kidney disease or retinopathy and neuropathy, we probably say, hey, if your diabetes is more progressive or uncontrolled, you're likely going to have higher cardiovascular risk. Therefore, we should treat you more aggressively with things like a high intensity statin. And if you're using that pooled cohort equation or that 10-year ASCVD risk tools in less than 20, and or without those factors, a moderate's appropriate. If our folks are less than 40, this is kind of where the data becomes a little more gray, but I think we're learning more and more and supporting that, hey, if people have diabetes in their 20s or 30s, or type 2 diabetes specifically, and you, just because you haven't turned 40 yet, the day you turn 39, from 39 to 40, your risk doesn't miraculously increase significantly, right? This is something that you have to look at the patient in front of you now. And then again, that last group of say, hey, we're going to look at our 10-year ASCVD risk. People, they don't have diabetes, they don't have ASCVD, they don't have an LDL of greater than 190, because we would have put them in some of those other buckets. But what else is happening, right? How can we assess their risk? If they're greater than 7.5, we probably should consider a statin, a moderate intensity statin, especially if they have what we call risk enhancing factors. These are things like family history, inflammatory conditions like HIV or rheumatoid arthritis, metabolic syndrome. So this is increased, waist circumference, for example, and a combination of a few other measures. They have increased triglycerides. They have decreased renal function. Right, all these different aspects are things that we know increase cardiovascular risk, but are not in our traditional pooled cohort equation. So I'm just going to say, I think that this is a great reference slide for you in the future to consider if you need, and we'll refer back to it a little bit throughout the day today. So in addition to just starting these therapies, again, we mentioned a little more about how in 2018 we wanted to be more aggressive and saying that we need to follow up, right? I think that now we kind of were set it and forget it, and really introducing it to say, hey, we got to do something here. We got to follow up, because there's more opportunity, right? If I'm saying you may need an ezetimibe in addition to your statin now, I got to make sure that I'm getting a pre-repeat LDL. So to summarize these guidances, our baseline lipid panel should be taken prior to starting any therapy. 4 to 12 weeks after new therapy or a change in dose, we should repeat a lipid panel. And then optimize any therapy if needed. So let's say you start somebody on a new statin, it's January 1st, right? Sometime in, February, March, April, we should be getting people on repeating that lipid panel and ensuring they're achieving their goal, right? So depending on your group we were just referring to, that may be a % reduction in LDL. Or it must be something that is a threshold. Regardless of what that patient's goals are, based upon whatever treatment category we were just describing, you should collect that and then likely repeat every 3 to 12 months if needed. It's going to be able to assess adherence as well as assess efficacy and if we need any titration of our treatment. Oftentimes, we obviously do get concerned and we hear a lot of issues related to statin-associated muscle symptoms as well as liver dysfunction. We're not needing to ongoing assess those things, such as LFTs and creatine kinase. Those are when issues arise. So let's say you start someone on a statin, they tell you they have increased muscle pain right after they started it. You took out many of the other risk factors or thinking of any other issues, like, let's say they just started to work out more often. And now we know, all right, it's appropriate time to use an LFT or a creatine kinase. This data on the right is actually some of the most significant to me. One of my colleagues, actually, when my co-residents back in the day had done a assessment of, let's look at some of the older guidelines and pre-2018 and post-2018, and let's see changes in did it actually, when we introduced those guidances to say you should be repeating a lipid panel in 4 to 12 weeks, did we get better at it? And this was about in 2019 or so. Newsflash, not much. And that we had to continue to be a bit better about how we are repeating these lipid panels. So, for example, after these guidances came out, only about 16% of folks at a new therapy or in a changing therapy were getting a repeat lipid panel at 3 months, and only about a third of patients at 6 months. Again, being the pharmacist brain that many of us have, right? We kind of got to be able to put in this idea to say we need this information to be able to appropriately manage our therapy. So, our first self-assessment question. So patient TT is a 50-year-old man with diabetes and a history of ischemic stroke. The most recent LDL is 120, and patient currently uses no therapy. Which of the following treatment is most appropriate? Is it ezetimibe 10 milligrams once a day, atorvastatin 20 milligrams once a day, rosuvastatin 20 milligrams once a day, or pitavastatin 4 milligrams once a day? Give you about a minute or so. It looks like that just popped up in the Zoom. Okay. Give you about 10 more seconds. Okay, great. So looking here, we're actually seeing pretty split between our atorvastatin 20 milligrams and rosuvastatin 20 milligrams. So let me dive into that a smidge for you here. When we're looking, we are seeing that, all right, patient kind of thinking back to this nice little workflow that we had created. So thinking to our patient, we're going to first ask, do they have a history of ASCVD? And yes, right, we have an ischemic stroke would be in that bucket of ASCVD. The trick was kind of they have diabetes, think moderate intensity statin is fine, but you really should be considering that they have an ischemic stroke as a first question. Once we know they have an ischemic stroke, now looking back up here, we're going to go kind of starting left to right. Yes, they have ASCVD. Yes, they're aged 18 to 75. They need to be on a high intensity statin at a minimum here. And then, we can talk more about treatment goals and thresholds as we go. But after we look at that and that they need to consider, all right, they should be on a high intensity statin, patient's not on any therapy. So I wouldn't consider that yet because they're not on a background of statin therapy first. And then our other statin therapies, now we need to parse out, are they moderate intensity or high intensity? Our atorvastatin 20 milligrams is actually a moderate intensity. Atorvastatin at less than 40 milligrams, so 20 or less, is considered moderate. And if it's a 40 to 80 is considered high intensity. Rosuvastatin 20 to 40 is high intensity. Anything less is moderate intensity. And then our pitavastatin 4 milligrams is also moderate intensity. So kind of a little bit of a trick in there, but I think a testament that this can get a little confusing at times, although it's always like, oh yeah, of course I know a statin, right? Making sure that we are kind of doing our due diligence and being as looking at closely at some of these different factors as we can. All right, second question here. Patient is GC, 60-year-old female with diabetes for 15 years. Most recent LDL is 100. Patients using metformin 1,000 twice a day, and the 10-year risk score is 5%. Patient has no other relevant past medical history. Which of the following is the most appropriate treatment option for the patient? Is it atorvastatin 40 milligrams, atorvastatin 20 milligrams, lovastatin 20 milligrams, or pravastatin 10 milligrams? See a lot of those responses coming in. Appreciate all the great engagement and some of the polling questions. It really does help, dictate if I got to go back and review some stuff. So, all right. We should be go ahead good here. It looks like we got over 3/4 of respondents. So seeing here a split a little bit between 40 and 20. Great conversation point. So kind of going off our original 2018 guidelines, which is our still our more robust practice. I'll share a little bit more of the updates from things like a consensus statement that ACC has put out. But looking here again at this patient, so 60 years old, diabetes, right? So we know they're going to that diabetes benefit group. 15 years really puts us in that they have a risk enhancer potentially, right? So really, I wanted this to be able to say it could go either way on this one, which is partially why I chose it this way. So, right, patient has an LDL of 100, which is their ASCVD risk score of 5%, right? So let's just kind of start from the baseline of the patient has diabetes. They should be on at least a moderate intensity statin because they're aged 40 to 75. Great. Now, considering the ASCVD risk score, we know 5%. 5% inherently would say moderate is still fine. If that number was above 20, we would probably be more aggressive and count to treat to the high intensity. However, the curveball, right, is that persistent length of time of diabetes treatment. So for 15 years, it is one of those diabetes risk enhancers we were discussing. I think you'll have some clinicians that would probably want to jump directly to the high. Most, I'm assuming, would probably start at moderate still. The reason that this is important is that these extra risk enhancers, all these factors, all these tools, they're just one aspect. And then you still have to add in your clinical decision making, right? A lot of this does have an algorithm. However, we know that it's not, algorithms aren't one size fit all. You could make the case either way in this scenario. Just from my own clinical experience, I would say most people would start at that moderate first, make sure it's tolerable, and then titrate if needed. But just having, let's say, a diabetes for more than 10 years does not automatically say you need 10. At a minimum, you need a high intensity. At a minimum, you would still need, but high would be an option. Great. So as we go to updates in our assessment, we're going to talk a little bit about some new biomarkers as well as a new tool. We had our Framingham before, our risk calculator, we have our pooled cohort equation, and now we're going to talk about prevent. Just thinking of these so you can be familiar as they come, right? You're going to hear a lot about many other things in the world of lipidology beyond just LDL, total cholesterol, HDL, etc. We have many of the different what we call apolipoproteins. These are kind of our markers of different LDL or cholesterol, our different cholesterol particles, right? Our lipoproteins. So as you see in this blue image on the top right here, the blue representing how much triglycerides we have and the yellow representing how much cholesterol. We have a wide amount of variability of the proportions and the ratios based upon which molecules we're looking at. So our chylomicrons are our really large, fluffy, triglyceride heavy. This is why they happen after you eat, because you have a lot of triglycerides after you eat. And then over time, you have your, you look at some of your LDL, for example, is much more cholesterol heavy. When we talk about some of these different aspects, you can see some of the different LDL, some of the different changes in the ratios. Well, each of these has a marker in what we call an apolipoprotein, in addition to all these ratios. So all of these different ones we have listed here have what we can call apolipoprotein B. B is actually indicative of something negative, and meaning it's pro-atherosclerotic, or it contributes to cardiovascular risk. I did see one question in the chat quick, but what was the correct answer? At a minimum, B is the correct answer. A could also be considered an option. So I would say B is the appropriate answer. A is an option based upon the individual patient. However, they both actually would be correct in clinical practice, and wanted to be able to have that discussion. Great. So as we consider here some of the different traditional lipid panels that we all know and love, we have the total cholesterol, the high density lipoprotein, and the triglycerides and the LDL. Who should really be getting these in practice? We know annual screening for those with diabetes or folks with established ASCVD. People with increased or borderline risk should be every 3 years, and the patient without any real risk or history would be about every 5 years. We have our traditional panel, but we know that as you have things such as higher triglycerides, they're not as accurate. We know that, as our lipoproteins, we calculate a lot of these things like LDL. So I'm not going to have to go into all the math today, but basically it's a combination of looking at your total cholesterol and your HDL, and looking at your triglycerides. But that may change, the calculation's a bit more affordable. If you need to, we can collect it direct. There's some conversation always of should it be fasting or non-fasting. Traditionally, we've been collected fasting, but we actually know that we may not need to for many of our patients unless they have elevated triglycerides. Ideally, the fasting is more accurate slightly. However, the feasibility and kind of the real world to send somebody away if they have an appointment at 2 o'clock or ask them, to not eat for a whole day until 2 would be quite tough. So really, I say some lipid panel is better than no lipid panel. And from there, you can adjust. And if you need to repeat for, let's say, fasting afterwards, you can. So as I want to talk about some of these updates and some of these new biomarkers, we have apolipoprotein B that I was starting to allude to. Think of this as a little tag on every quote unquote bad cholesterol particle, right? We have different formations based on if it's going in the liver or the intestines. And it's a better measure of the quantity of your pro-atherosclerotic particles because there's only one per molecule, right? So thinking about kind of what I was talking about earlier when we're going to measure things like LDL and such, we don't know how much actual cholesterol is in there or triglycerides are in there quite well because of those different ratios that we see among the different particles, as well as the large slew of different particles that I was sharing you earlier. So really, as we think about this is a good way to say how many bad particles do we have, which may actually be more accurate. We found many ways of assessing cardiovascular risk as opposed to LDL. We've taken people who've had these measures, compared it to kind of what would the LDL have been, what would the ApoB have been, and they were actually better predictors with ApoB than it would have been with LDL. And kind of thinking about how to put it into context and when you may consider this, for folks with high triglycerides, so because we know that lipid panel becomes less accurate. So, we know greater than 400 is really hard to use, but if those triglycerides are greater than 200, this may be an option. Or when people have low LDL. So if you're thinking like, I really still feel like I need a better picture of this patient's risk, this may be an appropriate option. And the interesting reason as to why is even with low LDL, if people had high ApoB, we knew that their increased risk of mortality was 18 to 23% higher, and their risk of MI was 49 to 82% higher. So really saying here that this is telling us a story that we're not seeing. Just moving along as we look at our Lp(a), we call it, or is a highly oxidative form of LDL that really promotes plaque and inflammation and calcification. This is kind of the new hot thing, to be honest, as we look in the world of lipids as well as cardiovascular risk, because it's kind of telling what we've always been interested in. So Lp(a) levels are a 70 to 90% genetically predetermined, right? Interestingly, your gene is expressed by age 2, and almost all Lp(a) levels are achieved by age 5, right? So think about how interesting this would be if we could assess cardiovascular risk in the teens, right? And have a great idea of what the differences are here. We don't see much improvement with meds currently. However, we're actually right on the forefront of a lot of new meds coming out that are specifically trying to target Lp(a). Because the hard part is it doesn't budge, right? We haven't seen people be able to move it much despite its really well ability to predict risk. So as we see, optimal Lp(a) is as low as 14 and greater than 50. But really why we say that is if you have a greater than 50, you're at double the risk of developing cardiovascular disease, right? This could be a one-time test that people get. And many of our lipid-focused organizations, such as like the National Lipid Association that I do work with, has really started to push to say we should be doing some universal screening for a lot of this to be able to make some more person-centered decisions. But really, again, mentioning there's not a lot of drugs that impact it now. Statins don't even change it much, maybe some diet and physical activity, but we're going to continue to learn a bit more here. I see somebody say about 55. We're getting there right now in the question and answer. Just quickly with our high sensitive C-reactive protein or CRP, this is again, we always assess this often when our inflammation or looking for those. We know inflammation is a big part of it, right? A lot of our conversation now is not to say, hey, this isn't just LDL, it's LDL and it's HSCRP together. So for example, those with high HSCRP and low HSCRP had an increased risk of cardiovascular risk among those with low pooled cohort equation of 7.5 of more than 68%, right? There's a huge unknown piece about, or I should say more continuing to growing knowledge base of how inflammation plays a role in cardiovascular disease, which is why we see conversations about folks with HIV, rheumatoid arthritis, or some of these other conditions being more and more important. So I see a couple questions. I want to keep going because there's some good, I'm going to get to kind of a revisit on some of this. Just reference here, coronary artery calcium score. This is really where you're going and looking and taking an image of the vasculature to be able to say, hey, all these other tools are to assess how much plaque you have in the coronary artery. Let's go look at it. Interestingly, if you're taking a chest CT, for example, you're going to be able to look at this. And now a lot of clinical practices are actually starting to, let's say you come in, in the emergency department, you have a cardiovascular, you have let's say, a risk of pneumonia, and they want to do a chest CT. They actually now have some AI tools that are going in and actually pulling and looking at those cross images, because although that wasn't the purpose of why you went in there, we collected this info. And now let's actually be able to get this coronary artery calcium score on our patients, because we know elevated CAC, we call it, is favoring statin therapy. So let's say it's really kind of like going in and snaking a pipe, but you're just getting it by taking an image, right? So you can actually go in, look, say, hey, you have a lot of occlusion, you don't have a lot of occlusion. If you don't have a lot of occlusion, maybe you don't need a statin, or you don't need some of these other therapies. It really is kind of like a way to refine the pooled cohort equation. So as we move on to our assessment questions here, which of the following biomarkers is primarily influenced by genetics and likely reaches peak concentrations in childhood? Lp(a), high sensitive C-reactive protein, apolipoprotein B, or non-HDL cholesterol? Right, a lot of great responses here. Give it 5 more seconds or so. All right, so we see here about 70% of folks said Lp(a). That's exactly right. Our HSCRP, our high sensitivity C-reactive protein, while some of these conditions may have some genetic component, right? HSCRP may change if you're, let's say, treating some of these underlying inflammatory conditions and getting those under control. And apolipoprotein B can change, just like LDL can change with things like diet and treatment. It's just a more refined way to kind of capture the amount of particles that we would traditionally have, and is just a little better way of assessing kind of what LDL was trying to assess, I guess I would say is the best way to describe it. Great. All right. So as we talk and continue on about our calculators, right? We know we've used risk calculators forever, right? We know that what do we do? It's a way to mathematically combine a lot of different factors, right? It's you able to look at lipids, look at some of these different aspects, and put them into the full context of a patient. Our pooled cohort equation has kind of been our gold standard for the last decade or so. Using folks with if it's widely utilized tool that can work for people 40 to 79 for a 10-year risk score, as well as those with a lifetime risk of 20 to 59. We look at things like age, sex, race, systolic blood pressure, total cholesterol, HDL, diabetes, smoking, and the use of any hypertension meds, right? A lot of these are just check boxes, yes, no, like, do you smoke or not smoke? Do you use an antihypertensive, yes or no? So there's limitations that exist, right? Using race as a widespread universal marker of the risk and limits, and the choices are only limited to black and white, it really isn't probably the best way to assess risk, and doesn't really accurately portray most patients. Potentially overestimates risk across all populations, and has many conditions that are not included. If you think back to what we were talking about why, let's say, including diabetes for 10 years or more, or HIV is what we call a risk enhancing factor. These are things we know are not included in this equation, but we know increase cardiovascular risk, right? So we kind of have to still look at that whole patient. And again, mentioned many of those aspects are dichotomized, meaning yes, no. But recently in 2023, we have a new tool called Prevent. The American Heart Association said, all right, we like the pooled cohort equation, but we need to get a little bit better at it. So they have a new tool called Prevent, which is looking at cardiovascular disease formation in general, ASCVD risk, and heart failure risk at 10 years and 30-year intervals. It also has the ability to talk about cardiovascular kidney metabolic syndrome, right? Or CKM. We know many of these drugs and treatments and all these different aspects, they're all intertwined, right? As you start to treat the cardiovascular risk, you're also helping the, you're helping the renal function and the metabolic, or when you treat metabolic, you're also decreasing cardiovascular and kidney. So as we focus more and more, we want to be able to look at these aspects so intertwined. So you can actually now in the Prevent calculator add in BMI or EGFR to create a more customized risk profile, as well as it does not include race. However, it does include things like a social deprivation index. So you actually put in a patient's zip code as an optional field. You can put in their A1C or their urine albumin creatinine ratio and really start to get that accurate picture for the patient. There's enough of starting to see that there's about potentially almost a 50% difference in the pooled cohort equation and Prevent in some patient populations. It really can impact statin therapy. And to be honest, our large guidelines have not come up with updates in this yet to say, you should use Prevent over pooled cohort equation. A lot of the data is starting to, people are trying this kind of out on different data sets now to see how it looks. So for example, looking here, going off of group of patients from 2017 to 2022 in the NHANES national sample, pooled cohort equation said 9.1%, Prevent said 4.7%, right? So we're seeing quite a difference there. In people with high risk, we know that it was about 12.5% of those with a pooled cohort equation and 0.4% with Prevent. So really trying to look and starting to see some interesting pieces to this. This is just another way to talk a representation of the Prevent calculator. I actually put the link right in there. So if this is something you haven't seen yet, to be able to go and take a look at. As we just kind of move on here, I want to be mindful of time and get to some of the treatment algorithms. A lot of this is likely review of many of the agents. We're in an interesting landscape where we have a lot of meds. Some may not always have actual data supporting their cardiovascular benefit. Things like niacin, fibrates, bile acid suppressants. We don't really have that benefit. They may change some lipid panels, but when assessed for cardiovascular mortality, we do not see any changes. Inclisiran has kind of been one that we likely assume is going to have it. This is an injectable. We'll talk a little bit more about that, but we don't have the data yet. It's coming in a little bit. Icosapent ethyl or IPE has data, but we don't really like it that much. So we don't include that too much, and that's more triglycerides focused. But then obviously our statins, we know our ezetimibe and our PCSK9s are largely most of the data is people on statin therapy already, but may not always be necessary depending on if the patient can't tolerate. So to the point about I kept mentioning some updates, there's a 2022 consensus pathway looking at basically saying, hey, it wasn't a full guideline, but we have a lot of new drugs in the market. We should probably start to put this into context of our current guidelines. I'm not going to dive too much in this just for the sake of time, but knowing that our statins are our main agent here, there's going to be differences in our statins based on their half-life and their metabolites, and they're going to have different drug-drug interactions. I want to leave this kind of here for reference, but same thing with ezetimibe. Most of us are likely very familiar with this. Decreases LDL by about 18 to 25%. It has benefit, right? It has cardiovascular benefit when added to statins. It really stops to block some of those cholesterol absorption from the small intestine. And it's the reason we like it. It's cheap, affordable. It's one tablet once a day, and it has very minimal side effects. Interestingly, a lot of the data now is starting to say, do we need to jump to high intensity statin before we add ezetimibe? Or can we get some benefit by a moderate intensity statin with ezetimibe? No clear clinical guidance is coming out at this time, but we're actually seeing patients, if potentially started at a moderate with a ezetimibe, they're actually less likely to stop therapy and have no difference in cardiovascular outcomes compared to a high intensity statin. So quite interesting, right? Seeing that this may be another option to help potentially mitigate what we see as often those statin-associated muscle symptoms. Our monoclonal antibodies, these were kind of our first non-statin big therapy that came out. they're really effective, right? They have about 50% reduction in LDL or more, minimal drug-drug interactions. They're really kind of what you would use, and only most commonly those adverse effects are similar to those with monoclonal antibodies. They can be pricey, but I always like to remind people, compared to like a GLP-1 or any agent, they actually are cheaper in many ways. And it's actually, I think folks hear that, they're like, whoa, I thought these were, these far away specialty drugs that you can't access anywhere. They're very accessible. They can be accessible. You usually like to, most insurances require use of ezetimibe first, just from a cost saving standpoint, to ensure a patient's still needed. But if you do this and a patient's still elevated, this is appropriate treatment. In people with established ASCVD, for example, or those with a familial history, or those just with an increased risk that we need further decreases on. But that's an at-home injectable. As opposed to inclisiran, which is a new agent, which actually is a small RNA molecule that is now indicated to reduce LDL and in patients with ASCVD, familial hypercholesterolemia, or increased primary prevention folks. I can't say cardiovascular disease yet because the data's not here yet. It should be coming next year. Why we like this? It's an injection at day 1, day 90, and then every 6 months. Right, so really thinking about how this is going to change the landscape of some of our adherence barriers, which we know has always been an issue with many of these therapies. It has to be administered in an infusion center by a clinician, so some of the payer might be a little bit more challenging to navigate at times. But as these results come on, a lot of our smaller studies have in an aggregate. So let's say all the studies that looked at LDL across different populations, when combined, demonstrated a decrease in cardiovascular risk by about 26%, but we likely don't have enough people yet to indicate this. This is probably one of my most interesting, I think, that's coming out, that is here now, which is bempedoic acid. It's the only drug that is oral non-statin therapy approved for people who are statin intolerant. So they were quite clever, I would say, when making this study, in that they looked at people who were not on statins. They had tried statins and failed. They were indicated for statins, and they found that when in a fixed dose combination with ezetimibe, which is actually comes in a single tablet, either bempedoic acid alone or in combination, it actually decreased events in people not on statins. That is very novel compared to how the other therapies are. And we saw reductions in a composite cardiovascular outcome. We saw decreases in LDL of about 25% or so, and decreases in inflammation. So it really is potentially an option. To be honest, I haven't seen it used a ton in practice yet. But with a combination with ezetimibe, we saw about changes about 30 to 40%. Sorry, the trial was actually just in bempedoic, not with the combo. So we see some concerns for increased uric acid, Achilles tendon rupture, and the cost is about $400 a month. So obviously more than a statin. But potentially is an option for those patients that really, really cannot take statin therapy, and those who may have issues with some injectables. So you see now, we're kind of painting a picture about how it's hard to kind of see how these things fit together. I'm not going to dive into too much of these. These are some pipeline meds coming soon. Some of them looking at Lp(a). Some of them are other oral options. Specifically, really in the familial space are those green one on the bottom, and the top ones here. So familial is kind of its own beast, and not a ton of patients we're going to see, but really can impact here. Looking lastly just at colchicine, obviously for some of you may be like, what are we doing with colchicine here? It was found in a series of clinical trials looking at colchicine at 0.5 milligrams, not 0.6, which is what we typically see for gout, in different groups of, post-MI or in different cardiovascular points, to see that it actually was reducing events. It was reducing any of those major cardiovascular outcomes in people with established risk, right? Why? Well, it's likely thinking that there is because of the inflammation component and what we traditionally use colchicine for. Obviously, we know folks can cause some GI distress, but it does have an indication now in a brand name of 0.5 of myocardial infarction, stroke, coronary revascularization decrease. We want to, of course, caution people with a history of renal dysfunction or hepatic dysfunction, and with a strong 3A4 inhibitors or PGP glycoproteins. But quite interesting seeing some of that. This is a new option and did decrease events with the data we have. Again, it's not really, I've not seen much guidance on how we want to put this into guidelines. I think that there's not been a ton, the folks would say they don't want you to use 0.6 because it has different profile of the some of the different kinetic parameters. So great. I'm not going to dive into this. I'm not going to post the assessment question. I'm just looking at this patient with a history of MI, 40 years old, refuses any injectable therapy here, with an LDL of 80 still. What would still be an option? Well, inclisiran is an injectable. Alirocumab, which is a monoclonal antibody, would be an injectable. Colchicine wouldn't necessarily be the right one here because we're not have any lipid lowering therapy, and colchicine doesn't really work on the lipids. So our bempedoic acid, our option C here, would be the great option in a patient who won't use a statin and is afraid, is already on a statin and would be a good add-on therapy as well. So the bempedoic acid can be add-on or can be used by itself. Just in summary here, we have kind of running short on time. I always want to chat about this stuff for a while. We have to consider a lot of things with our agents. What are the right one we should be using? What is the cost? What is the patient preference? So there was a couple comments. The highlights I want to have, I don't want to dive too much because some of this is a repeat. What we're seeing now in the 2020 consensus is that we should actually, there's a lot of options. So you could do things like ezetimibe and or bempedoic and or a PCSK9 or inclisiran. You don't use a PCSK9 and inclisiran together, but we have a lot more options. It's not as rigid as just one pathway as we've seen. And for people with very high risk, we kind of shifted everything down. We actually say we want to treat them to less than 55 now instead of 70, and anybody with ASCVD should be less than 70. So really thinking this through, as we see our patient here, this example of it, even with an LDL of 97, someone on atorvastatin with ASCVD, less than 55 may be our appropriate treatment threshold from there. I'm going to just go through, again, I want to be able to wrap up here. As we see, a lot of our patients can, both with ASCVD, the big takeaway that I would remind you is go to statin and then something else. Most people are in insurance, you're probably going to say ezetimibe. And then it really depends on how far you are away. If you need more aggressive treatment, something like a PCSK9 would be appropriate. If something was injectable, you may need, and if the patient is willing to do an injectable. When we look at diabetes without ASCVD, again, kind of similar mindset to say we've shifted to say even with 7.5%, you may want to target less than 70 potentially. I keep caveating this way and say less than 55, maybe less than 25. Less than 70, maybe, is because we really don't have this consensus. While I am in favor of it, I would say I don't want you to go run to every PCP you work with tomorrow and start to, be aggressive, trying to get everybody on here. I think that we're still learning a lot more about this data. I would feel comfortable doing this for this reason. However, we don't have that same multi-society endorsed guideline in which we do with our 2018 guidelines. So my advice is really 2018 is your basis, and then you're growing a little bit more with 2022 consensus statement. So seeing a lot of these here, again, a different, very similar application, someone on a moderate intensity statin with a history of diabetes, they're only seeing, they might have some issues, and how can we switch them to an appropriate therapy that may, be having missing therapy and using something like rosuvastatin. Sorry, going the wrong way. All right, very quickly at the end, HIV, this is potentially the newest, largest recommendation, a lot of where my research is. We've seen that in people with low ASCVD risk, as low as 5%, we had a first prospective intervention RCT of a statin versus placebo in people with HIV. And we actually saw it's almost as effective in people with HIV with the ASCVD risk score as low as 5% in people age 40 to 75 with a statin. So quite interestingly, really seeing significant benefit here. CDC guidelines now have a class 1A recommendation for people with HIV to be considered statin therapy. So a couple other info here. I know we're at time. Really just in conclusion, thinking about how LDL is changing, right? I hope I've encouraged many of you to think about the LDL today and to be able to guide your therapy in this treatment. Know there's a lot more options out there. And this is what's kind of leading to say, hey, do we need to go back into quality measures and start to say, I look at blood pressure to say how controlled is it? I look at A1C to see how controlled is it? But I don't necessarily look at LDL that way. We used to back in the day, but now we just say statin, no statin. But as we have more options and as we know that lower is better, this may be an appropriate measure for many of our patients. And we have a lot of other tools, right? We have ApoB, we have LP little a. We have a lot of new agents and new guidelines to assess. I hope this was a good primer to say the options are wide. I hope it encourages you to continue to look more, and that there is still a lot we're going to learn and need to do. That being said, I believe I am at time. I see one or two quick questions. How low is too low for cholesterol? New studies coming out showing people have been at 20 for like 5 years of an LDL, and there's still no difference in safety. We're looking at the PCSK9s that have been here for a long time and pushing that out now because they've been around since 2017 or so in many of these, seeing that it's okay. People said oil in the diet. Basically, end of the day, we like olive oils, olive oils, avocado oils. We like unsaturated oils better. Saturated oils are where we have many of our issues. Good rule of thumb is if the room temperature, it cools, or the higher the temperature that it becomes solid at is usually more indicative of higher cardiovascular risk. Not always though, but just always an interesting caveat for patients. So butter, like Crisco, for example, would be something that we would obviously say is worse. Someone said, can you give all the answers to the assessment questions? Yes, I can do that and have that sent out to you all after. I appreciate you kind of bearing with some of that timing wise. But I think it is a lot of great content and wanted to make sure you at least had the resources available. And that all being said, my info is right here. I'm not that far away from many of you over I'm right at University of Rhode Island. I live up in Providence. I'm super excited about this topic. If you ever have any questions or have any things that you'd like to connect on, again, my roles now is a lot more implementation and looking at pharmacy services and evaluation from a research lens. If there's ever opportunities where you have opportunities to collaborate or have any questions or can be a guidance to you based on today, please feel free to go ahead and shoot me an email. And this was really exciting. I appreciate all of your questions and engagement. So thank you so much. And I hope you enjoy the rest of your day.